I think it is 8 o'clock. Friends, good evening, everyone. On behalf of the senior faculty here, I wish all of you a very happy Makar Sankranti and wish you a very
Makar Sankranti, sir.
Makar Sankranti.
So I wish all of you a prosperous new year with lot of learning and a lot of success in your career on behalf of all the senior faculty.
Kanakvel, sir, I
Yes,
may
sir.
have to leave around 9:15. I may not be present for second case, sir.
Absolutely, sir. I understand, sir. I understand.
Okay,
Sir.
thank you very much. Please.
Thank you, sir.
Let us start.
Yes, sir. So we have a very eminent faculty today, Professor Erbas Momen from HTM Medical College, Mumbai, Professor Pankaj Modi, sir, from BJ Medical College, Ahmedabad, who's been always with us from the time of inception. And we are expecting Dr. Hemant Natyal from Himalayan Institute of Medical Sciences, Dehradun, shortly. And we have our senior faculty who have been with us almost from the inception, last 3 years. We have Professor Karnakaran, Professor Srinivasan, Professor Rajiv Sahai, and others are expected to join us shortly. And what I'm going to do is I'm going to mute everyone. Only the presenter and faculty, please unmute and start presenting. So the first case, I think, will be presented by Dr. Rakesh. Rakesh is kindly contributed by Ashwini Rural Medical College, Solapur, Professor Sachin Jamma, sir. He is going to present you a case of a malignant lump of the breast. And the second case is kindly contributed by Professor Srinivasan, sir. Again, quite some time we discussed the carcinoma of the penis. Dr. Archana is going to discuss about the growth in the penis. So first, let us have Dr. Rakesh to start his case. Dr. Rakesh,
yes, sir.
Introduce yourself, your unit chief, your head of the department, and start presenting. Good luck to you, Dr. Rakesh.
Thank you, sir.
Please start sharing your screen, Dr. Rakesh.
Yes, sir.
So generally, the student is allowed to present through the history without interruption. Stop there, and then faculty can revisit from the slide number 1, 2, 3 like that and ask questions. And then once you are convinced about his knowledge, I request you to tell the answers if the candidate is finding difficult to answer. Then we move on to the clinical part. Then we move on to the diagnostic and later to the management part also. So I wish you good luck, Dr. Rakesh. It's all yours.
Thank you, sir.
Right.
Am I audible and visible, sir?
You're perfectly audible and visible. Good luck to you.
Thank you, sir. Good evening, everyone present here. With the permission of esteemed panel, I would like to start presentation of my case under the guidance of Dr. Sachin Jamma, sir, Professor and HOD of Department of General Surgery at Ashwini Rural Medical College, Hospital and Research Center, Solapur. A 47-year-old lady resident of Barsi, married Solapur, married for last 20 years, farmer by occupation, presented to the surgical OPD of ARMCH Solapur with chief complaints of lump in left breast since one year, pain in left breast since 15 days, and reddish discharge from left nipple since 3 days. In history of present illness, she was apparently well 1 year ago when she noticed a lump in her left breast, which was initially of a small size about betel nut and insidious in onset, and gradually progressive for initial 2 months and rapidly progressive for last 8 months to the current size of a lemon. The lump was painless to begin with, and now she started complaining of pain in left breast since last 15 days, which is gradual in onset and non-progressive in severity, and dull aching, for which she was prescribed some ointment and analgesic by local physician, details of which is not available. The pain was relieved on medication with no aggravating factors. She also started complaining of reddish discharge from left nipple, which only occurred on pressing the lump, resulting in 1 to 2 drops of reddish discharge from the left nipple. She also gives history of loss of appetite since last 3 months and weight loss of around 10 kg in past 6 months. There was no history of decrease in size of a swelling, lump in right breast or axilla, or no history of trauma, fever, and there was no any history of back pain, abdominal pain, chest pain, or pain in upper and lower limb. She denies the history of cough and yellowish discoloration of eyes, and also she denies the history of headache, seizures, loss of consciousness, and any motor weakness. She is a non-diabetic and non-hypertensive. On evaluating the past history, she denies the history of pulmonary tuberculosis, no history of consumption of OC pills or hormone replacement therapy. There was no history of chemotherapy or radiation in the past. There was no history of chronic medical illness and no history of drug allergies. She has a history of appendicectomy done 13 years ago. On personal history, she consumes mixed diet with normal bowel and bladder habits and has normal sleep pattern. And she denies the history of any addictions. On menstrual history, she attained her menarche at the age of 12 years. Earlier, her cycle was used to be 28 days, of which the flow was for 3 days and regular. And since last 2 years, she present the history of menstrual history of cycle 2 months every 2 months and flow for 4 days and denies the history of passage of blood clots. On obstetric history, she is para 2 living 2 all full-term normal vaginal delivery, and her first child was female at the age of 19 years and second child is male at the age of 21 years. There was no history of abortion or miscarriage, and both pregnancies was uneventful. She breastfed both her children for 2 years. On family history, no history of breast cancer in first degree relatives or no history of any other malignancies in family like pancreatic, prostatic, colorectal or ovarian cancers. I would like to continue with my examination.
Dr. Rakesh.
Yes, sir.
Rakesh, please wait. Faculty will ask questions, then we move to the physical examination. Kanna sir, good evening, sir. Hemant sir, good evening, sir. Please take over, sir.
Okay, Dr. Rakesh, could you go to your first slide, please?
Yes, sir.
Okay, that's fine. So next slide, please. Look, we've always reiterated that the betel nut and lemon size should be interpreted in centimeters by you.
Okay, sir.
Okay, because the size of these things, they can vary. Betel nut can be very small or very large.
Yes,
so
sir.
can a lemon be, right?
Yes, sir.
Okay.
Because the present is what you are going to say. So it should be in centimeter. The
Yes,
idea
sir.
was that the previous one, you may not be aware what the patient is saying. But current size, you should mention exact size as the Sahai sir is saying. Yes.
Yes, sir.
Okay. You've said a history of discharge of nipple.
Yes, sir.
So is it from one breast or both the breasts?
Sir, one breast, only affected breast.
So that should be mentioned. That's not coming from the next other breast. And is there staining of the undergarment?
No, sir.
So that has to be mentioned because you said on expressing. But we would
Yes,
like
sir.
to know also whether the undergarments are stained.
Yes, sir.
Right. Sometimes patients can appreciate whether it's from a single duct or multiple duct.
Yes, sir.
So that should all be all. And you said about history of LMP, HRT.
Yes, sir.
What was the LMP? What was the patient's LMP?
Sir, her LFT was normal. Sir.
No, LMP, last menstrual period.
7 days ago, sir.
Right. So you think she would be on HRT if she's having periods?
No, sir.
Right. So I think it's not. If she's postmenopausal, then you can ask for HRT.
Yes, sir.
And you said pain for 1 month. Why do you think she's getting pain?
Sir, involvement of perineural invasion, sir, by malignant cells.
Okay. So the pain, you've not described the pain at all. The Socrates, site, onset, character, right? The pain has to be. Have you said? Gradual onset, non-progressive. Okay. Okay. Thank you.
Gradual in onset, non-progressive in severity, and dull aching in nature.
There's no The pain is not radiating to any place. Any precipitating factors?
Yes, sir. No precipitating factors and relieved on medications.
Right, sir. Sir Pankaj, sir, please.
Yeah. Why do you want to say that patient denies this history, that history? No history is sufficient. That means the patient might be a history, but patient is denying that she has this history. So it's matter. One more point I would like to, you have taken too much of history. Go next slide, please. Next.
Yes, sir.
That is fine. This all is right. You already
Yes,
mentioned non-diabetic and non-hypertensive. Next slide. You say no history of chronic medical illness. What do you mean by that?
Sir, thyroid disorders and
So you would say thyroid disease. The point here is what I want to say. There is no need of this much of past history to be spoken. Why do you want to ask history of chemotherapy and radiation without any history of any surgery or anything, lump or anything? Straightway history of chemotherapy and radiation. Why did you ask that history? If you had asked present, then remember there are certain history which if present you should mention, but their absence doesn't mean anything. What information did you get? No history of chemotherapy or radiation?
so if she has,
Yes. If it is related to this lump, then you should have mentioned in present illness.
yes, sir.
Past history, this is not a routine history you take or describe when you are mentioning past history. Do you understand? And
Yes, sir.
my advice is that if appendicectomy is not of significance related to this disease, you can skip it also. And do not go too much of information or too elaborate. Sometimes it can be a problem. Do you understand?
Yes, sir. Yes.
That this is not needed. Chronic medical is a drug allergy. Those are the, if present, they becomes important. We assume that you have asked. There is no need to ask such a detailed or at least mention such a detailed history because you don't have that kind of time.
Yes.
Do you understand? One more elementary mistake, you have mentioned 28 years and you have spoken 20 years of marriage. Do you understand? That is okay. It's a slip of tongue, but that's all right. What is significance of that? That's what I would like to ask.
Sir, if she marries at early age, then age at the marriage, first child is protective in breast cancer. Early age of first child is protective.
Now, early marriage for 28 years I am talking about. You have mentioned it, that's why I'm asking you. Does it make difference? It's what is more important in nulliparous or that? Do you understand? That is the more important. But you have mentioned it has no direct significance. It's a number of child or children that is important. Go to that slide, menstruation. So what I suggest in previous, cut it down. Do not go too much of elaborate in past history. Right?
Yes, sir.
Okay. So no. Go back. What do you mean by 2 months, 4 days? What does it mean? How do you call 2 months, 4 day regular cycle? I would like to know that.
Sir, since last 2 years, she is having cycles every 2 monthly and
Is it a regular cycle?
Regular, sir, but we can call it as a oligomenoric cycle, but still
How can you call it regular? What is a regular menstrual cycle?
Sir, menstrual cycle which comes every month.
So is it coming every month?
No, sir.
So you should say patient has an irregular menstruation. What I want to impress upon that, keep it simple. Do you understand? What do you mean by no history of passage of blood clots?
Sir, in perimenopausal period.
Again, it is too much of information.
Yes.
If it is present, then it is important. Otherwise, it is no. You can simply say patient has an irregular menstruation every 2 months.
Yes.
That's all. Do you understand? What is significance of that? Sir has asked similar question. Will you call this patient postmenopausal or not?
We can call them as a perimenopausal, sir, considering her age and cycle interval.
What is significance of that? What is significance of that?
Sir,
when you say patient is perimenopausal, what is significance of that?
Sir, In treatment, depending upon her age, we consider
Yes,
hormonal.
that is the
hormone-
important point. For
Yes,
a management part, this becomes very important. Next
Yes, sir.
slide. Next slide. This is the important. No, go back. This is the important history. Why did you mention first female, second male?
Sir,
Does it have any bearing on your management or in a diagnosis?
yes, sir. In genetic screening, as she is having breast cancer, we could screen her female child too if there is any BRCA related.
No, but what we are doing it for the, this is history is for patient. If first child is male and second is female, then doesn't
So
matter.
that,
Again,
yes, sir.
Two living child, one male, one female. That's all. Okay.
Yes, sir.
What do you mean by no history of abortion or miscarriage?
Sir,
You say P2L2. What does it mean?
parity to number of pregnancies cross the viable period.
What is viable period?
Sir, we consider nowadays we consider it as a 24 weeks of gestation.
Okay. Okay. Next slide.
What do you mean by that? Both pregnancies are uneventful.
I was going to ask, but I said it's okay, doesn't matter. Let's go. Because the what message we want to give is, Rakesh, doesn't matter. You have
Yes.
done, but you are giving too much of information. You may not reach up to investigation and management if you go on describing so many things. It is a very important point. Positive history is important. Negative is just showing the knowledge. Let the examiner ask that thing. Do not write down everything. You will not
Yes.
have a time. Look, answer the sir.
No, the child, the age difference is only 2 years, but you are also put as a breastfed for 2 years.
Yes, sir.
That is possible, no?
Could be possible, sir.
Could be possible. So in the full lactation period, normally it will not happen. Lactation amenorrhea will be there.
Yes, sir.
Okay. Now that is what sir is particularly saying. Don't give unnecessary, non-necessary details here, which will end up in trouble for you.
Okay. Again, next slide. Okay. How did you ask this history? No history of any other malignancy in family like pancreas, prostate, colorectal, or ovarian.
So these are
Oh, no, that we know. No, I'm not saying it is wrong or right. But how did you ask this history? I would really like to know, because I'm unable to ask such histories in my patients.
so if any her blood relatives underwent surgeries or chemoradiotherapy for any malignancies.
So the again message is same.
Yes,
This
sir.
is unnecessary. It is just showing off that you know this thing, and your whole viva may be upper. What is the relation of pancreatic malignancy with CA breast?
So in genetic,
Is it
genetic-
related? It is related. Pancreatic with CA breast.
yes,
I
sir.
can understand ovarian. You should have mentioned thyroid also then.
Sir, no, sir. There's pancreatic, prostatic, and colorectal and ovarian malignancies are genetically predisposed in a BRCA related malignancies.
So that's why you have detailed ask. Okay,
Yes.
how many sisters she has?
Sir,
That is the pitfall every student falls for.
yes, sir.
You have written first degree relatives and you don't know how many first degree relative patient has.
Yes.
How did her mother die, or is she alive?
No, sir.
No means not alive or
Not alive. Not alive, sir. She
How
died
did
of
she die?
ischemic heart disease.
Ischemic heart disease. And how many sisters she has?
Sir.
That is first degree, I think.
Yes, sir.
So how can you comprehensive say no breast cancer in first degree relatives? So the point is same, keep this thing. Rather than pointing upon pancreas, my advice to all students, when we are discussing CA breast, always know in detail about sister, about mother and daughter. Do you understand? It's very important point. Not that pancreas, prostate, that is for a genetics, is a very advanced. It is not in a history part. That's what I suggest. Sir, please. Okay. Continue. Now, the next part. So the principle is that keep it short and sweet.
Yes, sir.
Not fall in controversies. Because some examiners are like me, I like to tease. It's okay, continue, please.
With
Okay,
your
if
due
there is a history of surgery in the past, which history you are more interested? If there's a history of surgery is there,
yes, sir.
which history you are most interested?
Sir, breast lump, if any, and she underwent surgeries.
So which breast lump you are interested?
Sir, I don't get you the.
What type of lump?
What type of the lump where you are interested that the patient may have the malignancy? Any benign breast, you know, where the patient can have the malignancy? And the
Yes,
patient
sir.
has undergone the surgery for that?
Yes, sir. Phyllodes tumors.
Okay, one is phyllodes tumor, okay.
Yes, sir.
Anything related to the carcinoma of the breast?
Ductal carcinoma in situ, which is considered as a benign condition nowadays.
No,
Lobular, sir.
no, not ductal, not lobular. Anything else in the benign one? Have you heard the name ADH?
Typical hyperplasia.
ADH? Atypical?
Ductal hyperplasia. Yes, sir.
Yeah, so that is the most important benign breast condition which is likely to have a chance of malignancy.
Yes, sir.
Okay. Okay. Can you tell the difference between a familial breast cancer and a hereditary breast cancer?
So, in familial breast cancer, if any of her first degree relatives, sister, mother, or daughter is that is a genetic breast cancer, sir. If any of her first degree relatives like mother, daughter,
There's nothing like a genetic
something
breast
like that.
cancer. It is familial breast cancer or
And
hereditary
hereditary.
breast cancer.
Yes, sir.
So tell what is
Hereditary.
familial breast cancer and what is hereditary breast cancer.
Sir,
What is hereditary? What is familial?
the hereditary is if any of her daughter, sister, or mother having
No,
that
it is not with the who is getting. So how that hereditary or familial it differs.
If somebody has got the BRCA1-2 mutation is there, is that familial or hereditary?
that is hereditary, sir. Malignancy caused by genetic mutations are hereditary, and environmental factors familial.
Yes. Environmental factor plus also there can be other factors.
Yes, sir.
Okay. So if there is a mutation is there, then that is a hereditary breast cancer. Okay.
You
Can
ask
you tell what are the absolute risk factors for the malignancy and relative risk factor for the malignancy?
So there are modifiable and non-modifiable risk factors for malignancies,
Yes.
and non-modifiable are absolute risk factor, and modifiable
So can you tell what are those absolute risk factors?
modifiables are addictions like tobacco and sedentary lifestyle, night shift workers.
Yes. And absolute risk factors? What are absolute risk factors?
Non-modifiable like age and age
Yes.
at the menarche, early menarche, and late menopause are considered as a risk factor.
No, that is not absolute, no?
Yes.
There are only 5 or 6 absolute risk factors. Okay. Rest all other which are there, they are relative risk factors. So the patient may be nulliparous, the patient may not have fed the babies. All those things are relative risk factors because
Yes, sir.
the chance of conversion to the malignancy is very low in those cases. So the absolute risk factors are only age of the patient. If there is a history in the family is there,
Yes, sir.
the
Family
patient
history.
herself has suffered from the breast cancer. If the patient had a benign breast disease and it came out to be atypical ductal hyperplasia or DCIS, or the patient is BRCA1/2 positive.
Yes, sir.
Okay, so these are the only absolute risk factors. Rest all other which are there, they are the
Relative risk.
modifiable and relative risk factors. Okay. Yeah, you can go to the examination now. Yeah.
With your due permission, I would like to continue with my examination section. On general physical examination, I examined her in a sitting position under broad daylight in presence of female attendant after taking due consent. She was conscious, alert, cooperative, and well-oriented to time, place, and person, and her performance status was 90 by Karnofsky performance scale. She was nutritionally preserved and obese on account of BMI 36.3 kg per meter square, and she was well hydrated. Her pulse rate was 76 beats per minute in right radial artery and regular with normal volume and character without any radial or radiofemoral delay. Her blood pressure was 130 by 80 millimeters of mercury taken in left arm supine position. Her respiratory rate was 14 breaths per minute, regular and thoraco-abdominal type of respiration. There was no pallor, cyanosis, ectorus, and clubbing or pedal edema, and there is no generalized lymphadenopathy. On systemic examination, her systemic examination was normal. Examination of cardiovascular, central nervous system, respiratory system, and per-abdominal examination was normal. I would like to continue with examination of breast. She was examined with her consent in presence of female attendant in a well-lit room, exposing both breast and axilla and abdomen in sitting position with hands on waist and also in supine position. These are the images of while examining her. This is in supine position of bilateral breast, exposing bilateral breast and abdomen. And one image is image on right side is of in affected breast. This is image in supine position. On inspection, right breast and axilla were normal and breasts are asymmetrical. Left breast shows nipple areolar complex at higher level and appears larger than right breast. On bending forward, right breast falls forward. On lying down, the right breast falls away from the body, that is deviated outwards. There was visible circumferential retraction of nipple present on left side. There was no evidence of cracking, ulcer, eczema over both nipple areolar complex on both breasts. Skin over left breast was showing pude orange changes in lower inner quadrant. Dimpling present over lower inner and lower outer quadrant of the left side on raising both arms. Yes, sir. There was no evidence of dilated veins, ulceration, scar marks, pigmentation on both breasts, or fungating mass over both breasts, and there was no evidence of swelling of left upper limb. On palpation, I would like to confirm my inspectory findings. There was no loco-regional temperature. There was no loco-regional temperature raised on both breasts and no tenderness on both breasts. There was a single lump, ill-defined with uneven surface and irregular margins, oval-shaped and of size about 10 by 5 centimeter in its greatest dimension, present in left breast involving upper outer, lower outer and lower inner quadrant, which is hard in consistency and fixed to the overlying skin. The lump was moving slightly within the breast tissue and not fixed to the underlying structures, that is pectoralis major muscle or to the chest wall. On examination of axillae, no palpable lymph nodes was present in right axilla. Multiple hard fixed lymph nodes to the underlying structure present in left axilla. Pectoral, lateral, and posterior group of lymph nodes palpable on left side. Examination of thoracic and lumbar spine were normal. I would like per vaginal and per rectal examination was normal, and bilateral supraclavicular regions are not full. Examination of bilateral supraclavicular and cervical lymph nodes were normal. To summarize, a 47-year-old perimenopausal lady with lump in left breast since 1 year, rapidly progressive in size since 8 months with history of circumferential nipple retraction and painless initially and painful subsequently since last 15 days, and bloody nipple discharge since last 3 days. No history suggestive of distant metastasis. No history of menstrual irregularity, abortion, miscarriage, or hormone replacement therapy. On examination, 10 by 5 centimeters hard lump in upper outer, lower outer, and lower inner quadrant of left breast with irregular surface with no fixity to skin, pectoralis, with fixity to skin, no fixity to pectoralis major or chest wall with multiple hard ipsilateral lymph node in axilla. There was no contributory factors in medical history. Based on clinical history and examination, I would like to present my provisional diagnosis of 47-year-old perimenopausal lady with locally advanced carcinoma of left breast, and my clinical stage was T4B, N2A, and M0.
Rakesh, before
Yes, sir.
discussing anything, you said retraction of nipple, right?
Yes, sir. Yes, sir.
So did you ask that history? Was it a recent retraction? I didn't see anything about retraction in history.
Yes, sir. It
So
was
is it-
not recent retraction, sir. It was present there since last 8 months.
But 8 months is after lump.
No, sir.
The lump
Yes,
is since 1 year.
lump itself is of 1 year and retraction is of 8 months, sir.
So have you asked that history? I didn't see anything in history.
Yes, sir.
Second point is, I think I'm really confused whether you are describing right breast or left breast. So I don't know about anybody, but what I suggest is that you say the right breast is normal first, and then
Yes,
go
sir.
to that left breast. You are sometimes jumping to left breast, sometimes right breast. I don't know exactly what you want to say. Third is summary is as long as history. Why did you mention about medical history, no medical history in summary? I would really like to know that.
Sir, if there is no any medical history contributing to
To
the
what?
sir,
Lump,
lump.
contributing to lump.
Which medical history will contribute to carcinoma?
Another point in summary, no history suggestive of distant metastasis. What do you mean by? You have said no history of menstrual irregularity. There is a history of menstrual irregularity.
Yes, sir.
That you have said no history of that. These all doesn't come in summary. Do you understand?
Yes,
Summary means what is positive and important. How
Yes.
did you conclude that no history suggestive? What are the history suggestive of distant metastasis?
Sir, bone pains, like what back pain and shoulder and hip and knee joint pain.
You have mentioned those things in history.
Yes, sir.
Okay, great.
Yeah.
Right.
Dr. Rakesh,
Yes, sir.
hello.
Yes, sir. Yes.
You said there is no history of generalized lymphadenopathy.
Yes, sir.
What is generalized lymphadenopathy?
Sir, involvement of 2 or more than 2 non-contiguous regional lymph nodes.
Right. So, do you think from a provisional diagnosis, the breast carcinoma presents as generalized lymphadenopathy?
No, sir.
So you should have mentioned there is no axillary lymph nodes or cervical lymph nodes, right?
Yes.
Instead of giving because causes of generalized lymphadenopathy are different.
Yes. Yes, sir.
And usually falls in general examination.
Yeah. And one more thing. Hello.
Yes, sir.
Rakesh.
Yes, sir.
I was mute at that time. You said the full term normal delivery, right?
Yes,
In
yes,
your
sir.
history. What is the definition of normal delivery?
Sir, without any instrumentation
Normal delivery means the full term. It includes,
yes, sir.
right? So
Yes, sir, yes.
premature or post-mature baby. So normal delivery includes a full term baby without any instrumentation per vaginal delivery, no complication to mother and fetus.
Yes,
And
yes,
in the third, fourth line, you had written both the deliveries were uneventful. So once you have mentioned normal delivery, then there is no sense of writing that both the deliveries were uneventful.
Yes, mentioned pregnancy is uneventful, not delivery.
Yeah. Okay.
Again,
so
now
pregnancy-
instrumentation
Yeah,
is not normal delivery. Suppose you put a episiotomy, is it a normal delivery or
sir, normal delivery.
So you said no instrumentation.
Sir, that's
No, sir,
what
that is forceps. Forceps. Yeah.
Ah,
Delivery, applying a forceps is not a normal delivery.
normal.
That is.
What
yeah.
lesson learned, Rakesh, is? What is the lesson learned here?
Sir, no need to put unnecessary negative.
Unnecessary.
Nay, do not try to impress examiner.
Yes, sir.
Be simple. That is the point. That is, you are trying to show your theory knowledge in your practical. That's the problem. You understand? Go back now to the examination part, local examination.
No, you do general exam, systemic examination before instruction
Okay.
of the local dress.
Yes, that's what the another point I wanted to say. Usually, it is a routine that you do local examination first, followed by systemic examination. You have reversed the trend here. That's, sir, Jailal sir, you want to say the same thing, I think.
Yeah, yes, definitely. Normally we don't do because we confirm the diagnosis, then you go for your systemic examination.
Because the point here is that why is it like that? Once you do local examination, you realize that patient has a probably CA breast. So when you do systemic examination, then you give importance to whether liver is palpable, ascites is there, what is the site of bone pain in PRPV, is there a Krukenberg tumor or anything else. That's why, because you should know, establish the diagnosis, then check the system for the thing. Chest you have to examine. You have first cleared the chest, now it is cleared. Now you will go for CA breast. That's the point.
Yes, sir.
Rakesh, you
Yes, sir.
general examination said sitting position under broad daylight.
Yes, sir.
Is it necessary to examine a breast lump in a broad daylight?
Like jaundice.
So why you are making an unnecessary comment? It's not necessary to examine a breast lump in a broad daylight.
Actually, you should be saying adequate light. That's
Yeah.
it.
Yes, sir.
If at all you want to say.
That is implied.
Adequate.
Whenever you are examining, it is implied that you are examining the patient in an adequate light. So it's an unnecessary statement you have written.
Yes.
Okay.
BMA will give you the nutritional assessment also. You said nutritionally preserved and obese on account of BMA.
36.3 kg per meter square.
Will the BMA will give you the nutritional assessment?
Yes, sir.
What you mean? The BMA is high means they are well nourished.
What, sir?
But suppose the BMA is high, that means the nutrition is very good.
Nutrition is in excess, sir.
Excess.
Access.
The measures for nutrition is entirely different and measures for the obesity which you are talking.
Obesity. Yeah. So next question could be, what are the deficiencies you get in obese patients? Nutritional deficiencies.
Look what is happening when you are giving too much of information. It is a case of CA breast. Now we are going to obesity. You have to answer it now. The question is raised.
What is that meter square stand for there?
Sir, to calculate the BMI, there is a formula. We divide the
When
weight.
you are putting, you will write the formula also. No,
Let him go. Let him go, sir.
Let
Please.
him, yeah.
Let us go to next.
For chemotherapy drugs. So what is your normal surface area? What is your surface area?
There is a standard for that range. 1 point something. You don't know that?
The weight, you have a surface area is also standardized, no? For optimum weight.
Okay. Let's go to next. Local examination. Okay, next. Yes. You have mentioned enlarge. What do you mean by that? Appears larger than right. What does it mean?
Sir, there was a fullness of upper outer quadrant due to lump. Upper outer and lower outer quadrant due to the lump, because of which the left breast appears larger than right.
Okay, so you are talking about breast.
Yes, sir.
I thought you are talking about nipple areola complex. Sorry.
Left breast nipple areolar complex at higher level compared to right, and left breast
Higher
is
level I
larger
can
than.
understand. Larger I don't
Yes.
understand. That's the problem.
So, but
Another question I have got. You already established right breast and axilla are normal. Why every time you are saying the bending forward, right breast bend forward, right breast fall away from that? Are we talking about right breast or left breast?
Left breast, sir.
So once you say
suddenly
right
you are
breast,
saying the right breast. The mention
sir.
is the right breast falls forward.
Yeah, I think
What happened to the left
clerical.
breast?
Yeah, clerical mistake, I think.
no, I think he says it falls forward. The opposite breast doesn't fall forward. I don't know what he wants to say.
Yes, sir. The opposite breast, left breast doesn't fall as forward as right breast does.
So where you have written that?
So you will write something,
Yeah.
and examiner has to presume that you are written like that.
Yeah, because he has already written right breast and axilla normal, then again describing the right breast.
So that's what I'm trying to tell you. Once you establish it is normal, it goes without saying it is normal. No need to mention it. So why did you mention that left breast, right breast falls forward, and you are not written implied that left breast doesn't fall forward? What does it mean? What is meaning of that? When you say left breast doesn't fall forward, that's what you want to say.
Yes, sir. Left breast is adherent to the underlying structures.
Is it a breast
But
which is adherent?
later you have said it is not adherent to pectoralis major and chest wall. I saw in the palpation or inspection you have written that it is not adherent. Now you are saying it is adherent.
Yes.
Sir,
What is it?
the finding of this inspection on bending forward, the left breast doesn't fall forward. That does mean the breast could be the lump could be adherent to the underlying structures.
But it was not.
But
On
yes, sir.
palpation, it was not. Okay.
Yes, sir.
Then why it has not falls forward?
Okay, Rakesh, before I just like to ask you one. How will you know whether the lump is attached to the chest wall or to the pectoralis major muscle? How will you distinguish between the two?
Sir, for pectoralis major, I would ask patient to keep her both hands on waist and
Fine. That's fine.
Yes, sir. Yes,
What
sir.
about chest wall now?
Sir, without touching the pectoralis muscle, also the lump doesn't move. That means the lump could be adherent to the chest wall, like intercostal muscles, ribs, or pectoralis.
No,
spinal.
Rakesh.
Yes, sir.
If the patient bends forward and the breast or the lump doesn't fall forward,
Yes, sir.
that means it's attached to the underlying structure. That could be attached to the pectoralis major or it could be attached to the
Chest
wall, right? Now we have to do the test whether it's attached to the pectoralis major or not.
Yes, sir.
That's what people are asking you.
Sir, on touching pectoralis major.
That's right. We've got it. This is what I tried to tell you, that you first ask the patient to bend forward. If the breast tissue doesn't fall forward, then it's attached to the underlying tissue. Then you have to find out which tissue is it attached to. Is it the pec major or is it the chest wall? And then you do the test.
Yes.
Got it? Okay.
Yes.
The new line you have written, the breast falls away from the body. Right breast falls away from the body.
Deviated outwards. Yes.
What does that mean?
Rakesh, you're giving too much information. This is like an MBBS history and examination. I'll tell you what. You're just trying to describe everything in the short 10-15 minutes, right? You're going to be a surgeon. I would like you to talk like a surgeon, which anything, breast tissue falling away from the body, right tissue, the right breast, it doesn't mean anything. It doesn't give you, because the right breast is normal, isn't it? The left breast is the one that's affected. So how will it
mention right breast and axilla are normal? So don't
just write it is normal, then you don't have to write all this.
Yes, sir.
The same thing you are written in a general examination, the radial delay, radiofemoral delay. So all that please try to avoid. Okay.
It's not
It is
required.
necessary for this case. Try to.
And another point is you are describing left breast nipple area complex as higher level, right? So
Yes.
you didn't examine retraction at that time. Why did you have to write down it separately or speak it separately? When you examine nipple, everything you describe simultaneously. Do you understand? Don't make this. This is a very simple elementary mistake. You have described nipple area complex at higher level and the retraction is later. Why? You understand? So make it, as the sir is saying, make it a fluent history.
Yes, sir.
Do not
I
try
will
to
add
cover it.
your valuable inputs and make my history better, sir, next time.
It's
Good,
okay,
good.
doesn't matter. Next time it's a different thing, then we are just pointing it out. So when you say nipple areola, make it habit. The same thing, right breast over and out. Now don't speak about it. Left breast, start from that. Do you understand? Go to next now.
Rakesh, if the lump is in the left lower quadrant and it's a mobile
Yes.
lump, is it still fixed to a chest wall or not?
So the lump is involving left upper outer, lower outer, and lower inner quadrant, sir. Still slightly movable.
No, I'm asking you if a
Yes,
lump is situated in the lower outer quadrant, but it is
Yes,
a
sir.
mobile lump.
Yes, sir.
So can you say it is still fixed to the chest wall or not?
Sir, not fixed to the chest wall if it is mobile.
What is the muscle underlying there? Which muscle is there underlying?
Left outer quadrant.
Pectoralis.
Left
That
lower
is all
outer
over the
quadrant.
chest, that is all over chest. In that, specifically, I'm asking left lower quadrant. Not lower outer quadrant.
Sir, serratus.
Serratus anterior.
Yes, sir.
So if the lump is fixed to the serratus anterior, will it be mobile or not?
Sir, not mobile.
Unless you compress against the wall or against the patient, isn't? You
Yes,
make
sir.
the serratus anterior taut. Then
Yes,
it
sir.
will be mobile. But otherwise it will be mobile.
Yes, sir.
Okay. So the reason for asking this is that if the lump in the lower outer quadrant is there, it is mobile, still it can be fixed to the chest wall. And chest wall is the serratus anterior here. Okay.
Yes, sir.
Okay.
Yes. The next is again the same thing you have repeated. Both side is wrong. I think we have already covered it many a time. Okay, skin over left breast.
Yes, sir.
Well, so you said PUD orange. What does it mean? Very simple
Sir,
question, no tricky.
dermal infiltration. Dermal lymphatics are infiltrated with malignant cells.
But why
Oh.
there is, sir?
No, so what?
Sir, while examining the sweat glands and sebaceous glands present there doesn't come up. There was a edema and due to skin involvement. That suggests skin is involved. Sir.
No, is it just because lymphatic is infiltrated or is it
skin?
blocked?
Sir, skin involvement. It suggests skin involvement.
No, you said there is now the tumor cells are inside the lymphatics.
Yes, sir.
Then how can it be a dermal infiltration? There must be lymphatic block. There see the cutaneous lymphatics are blocked. So there is extravasation of the tumor cells comes into the dermal cell.
Yes,
It's not
sir.
just because it is in the lymphatics, it will not be called as a PUDR. It will not produce because it will go. Lymphatics are connected with everywhere.
Yes, sir.
When it is blocked, because the tumor clogging, it get blocked, it get extravasate, then comes to the dermal infiltration.
Yes,
And
sir.
it causes edema and in between tissue remains pitted. That's why the word PUD orange.
Yes, sir.
And is it actually a skin involvement? So what are the
So-
various type of skin involvement you see?
Ulceration and
In nodules.
That's it.
ulceration, eczema, and satellite
Eczema does
nodules.
not occur on skin. Beta.
Nodules, okay.
You read the dimpling. You know what is
Yes.
puckering?
So the involvement of multiple Cooper's ligament is puckering, and single Cooper ligament is known as dimpling.
So dimpling is present.
Yes, sir.
You look for some pigmentation on the breast. Why? You look said there's no pigmentation. Why do you want to look for pigmentation? On what condition you get a pigmentation in the breast?
So again, too much of information. And why do you say no evidence of fungating mass? Those are things, if present, you have to mention.
Yes, sir.
And examination is not negative for such things.
Yes.
Right?
Swelling of upper limb is due to what?
Due to what? Yes, that is important. That, yes, I agree with that part.
Sir,
Visual cause. And that should come after
lymphedema
axilla
due
actually.
to lymphatic
Only
lymphatic blockage.
cause an edema?
What, sir?
No, is it a lymphatic obstruction alone will cause edema? Or any other cause for edema there?
So if axillary lymph nodes are involved and there is a lymphatic blockage, it can cause a swelling of upper limb.
Upper limb, which part? Normally, lymphatic edema starts from where? You don't get into the upper arm. Starts from
Yes.
the forearm area. It
Yes,
is
sir.
from low upwards. So if you are seeing an acute edema on the upper arm, you must rule out venous edema.
Yes, sir.
Now it can compress upon the axillary vein, cephalic vein, it is draining into that. So that can cause an edema there. So don't think just edema you are looking for, not only for lymphatic, but also for a venous edema is also possible.
Yes.
Yes. And you have written swelling. What is that?
Sir, swelling of left upper limb.
So is it edema or something else also?
It could be something else also.
Like?
Sir.
Like, can there be a solid swelling of upper arm? Can there be a presence of swellings on upper arm? There is a difference. Edema and swelling is a different thing.
Yes.
What is cancer and cuirassive?
Sir, involvement of dermal lymphatics of extensive dermal infiltration of cancer cells involving entire breast and upper limb, and sometimes even opposite breast too. It is very aggressive cancer.
Anything peculiar about the cutaneous lymphatics of the breast?
Okay.
It is morely or less zonal level. It is in a segmental level. Then segmental vessels do not communicate with the next. So that's why one area, if you get, there will be an accumulation of this nodule you are going to get. Not like a typical satellite nodule. The cancer in cuirassive where you are getting here is not on the pathway of that because it is not directly communicating. It is most of the lymphatics are segmental lymphatics.
Yes.
And they are more common after surgery rather than that,
Yeah.
or radiotherapy like that, rather than primarily.
Yes.
Okay, I think we are short of time. Let us go next. Okay. Again, you are going both breast. And this is what the sir said. It looks like MBBS history. You should be fluid. A large, ill-defined with everything, single lump. It should be in one line. Do you understand what I want to say?
Yes.
Right. Okay. Fixed to, how did you know that it is fixed to overlying skin?
So there was a pinch and inch test I did, and it was not fixed to over entire lump, but it was fixed in lower inner quadrant, where on pinching a skin was not possible. Sir.
Why it is fixed to the skin?
So skin pinching was not possible in lower outer quadrants.
Yes, sir is asking something different.
You said there is only one dimple in the history. You said that you can see one area. There is a dimple is a very small part. One dimple
Yes,
you are seeing. The rest of the area is normal.
Yes, sir.
This skin is attached to that because of PDRS.
I couldn't get you, sir. Sorry.
No.
Rakesh. Sorry.
Yes, sir.
Yes, please.
Rakesh,
Yes, sir.
is there a better way of finding out whether the lump is attached to the skin or not? Because
Yeah.
pinching, you may pinch 500 places, but it could be attached at the 501st place and you may miss it. So is there a better way? What is Plato sign? Have you heard of it? So if you
No,
move the
I would
lump,
like to add.
yeah, if
Update
you
my
move the
knowledge.
right, if you move the lump and a portion of the skin moves along with it,
Yeah.
Yes, sir.
then you know it's attached, right? So this
It is known
pinching
as a-
business, right?
It is known as a sliding test. That's what
Sliding test of Plato side, right?
right.
That's the better way.
That is better. That's what I was,
Yes, sir.
was asking actually. Do you understand? That's the point you should understand. PUD orange or a dimpling on its own is not an involvement, right? So
Yes.
what is difference between ulceration and fungation?
Sir, ulceration occurs from and over anterior to, and fungation mass grows from
No.
inwards
What
to
is
outward.
ulceration and what is fungation?
Sir, ulceration is breaking continuity of epithelium, which can occur from external factors too, and fungation where mass grows from inwards to outward and it is irregular.
Is there any test to differentiate these two? If it is there, how will you differentiate that this patient has ulceration? It's actually a pressure necrosis, you can call it, like because of the large mass skin gets revitalized and gives way,
Yes.
or because of some application from external, as you have said.
Yes.
And fungation is an overgrowth of the tumor itself. So
Yes,
if it is there, how will you differentiate? Okay, this patient has ulceration and this patient has a fungation.
Large tumor can ulcerate.
Yes, sir.
So how will you differentiate? Clinically, any test is there?
What's his name?
I will update my knowledge regarding this.
Any probe test?
Dr. Rakesh, yeah, Dr. Rakesh. Look, you just said that ulceration is when the epithelial layer is gone, right?
Yes, sir.
There's discontinuity. So which is the epithelial layer? Is the skin. Now, if the tumor itself gets necrosed, right, and
Yes,
pops out from that breach in skin, what will you call it?
sir, fungating mass.
Right, it's called fungating mass. So fungation is when the tumor gets involved. It
Yes, sir.
pops out.
Yes, sir.
Ulceration is just the skin getting lost.
Yeah. So the sir is saying when ulceration is there, there is a probe test, sir is said. So there is a free space between tumor and skin, which won't be there in case of fungation.
Yes.
Right?
Yes,
Okay.
sir.
Next. This is again a very tricky, moving slightly within breast. What is that?
Surgeon should be very specific. You can't use all these words slightly.
You can't write two boards at one time, Dr. Rakesh. You can't say it could be day and it could be night. Right? Be specific. Okay.
Yes, sir.
Does it move or it does not move? It's so large, so it may not move.
Is it moves along with the breast tissue or within the breast tissue?
Within the breast tissue, sir.
That means it is could be a fibroadenoma.
Yes, sir.
Are?
Sir, there was PUD orange and dimpling and irregular surface on palpation.
Can a benign lesion produce a PUD orange-like lesion?
No, sir.
No.
Yes,
No.
of course.
Yes.
Yes.
What
Okay.
is PUD orange? What's the basis of PUD orange, Rakesh?
Sir,
I
obstruction
think we
of
have, sir,
subduct.
covered it. We have covered it. He has answered. It's
But
okay.
in any inflammation will also lead to PUD orange.
And
Yeah.
even you
Yes.
could see some like this. Please don't mention like this. If you say moving slightly and it could be possibly a fibroadenoma, that means the wavering way in which you are examining the case, or you are not confident of your examination.
What I was going to say is that when you are very sure that you have already put a diagnosis of malignancy, why you are bringing fibroadenoma in a picture? Here you are not sure. That's why I say moving slightly. When you say slightly, it doesn't move. Do you understand? And the tumor, 10 centimeter tumor, if it is moving, what will be your diagnosis? Without PUD orange and everything, if 10 centimeter tumor is moving inside the breast, skin is not involved, what will be your diagnosis?
Fibroadenoma will be 3 to 4 centimeter. If it is
10
5
centimeter.
it's called giant fibroadenoma.
Giant fibroadenoma, sir, more
No,
than 5.
10 centimeter lesions are saying that what will else other than fibroadenoma thing, and especially in the lady like 47, 45 years old. Any other tumor, benign tumor?
Could be phylloid tumors.
Yes.
Thyroid, yes, that's it.
Right.
Okay.
Right.
Not fixed to underlying structures. As sir has already covered, I will not be there. Don't write down only pectoralis.
Yes, sir.
Because at the different quadrant, other muscle comes into action. So how did you decide it was not moving with pectoralis major?
Sir, on torting pectoralis major muscle and moving the lump against the fibers of pectoralis major,
In which direction you will move the?
perpendicular to the fibers of the pectoralis major.
What is the origin? What is the insertion of pectoralis major?
What, sir?
Origin and insertion of pectoralis major.
Origin. Achha.
Then only you know the direction, no?
Yes, sir.
Yes.
Sir, lateral border of sternum and rib and
So the point here is that you should know these are basic things, right? Another question related to that. How will you know that pectoralis patient has contracted pectoralis major muscle?
sir, asking her to put her hands
That
on,
is the method to do, but you will know she has done properly. How will you know?
Immediately she is doing that. How will you check?
sir, palpating the anterior axillary fold.
Good.
Yes, contracted.
Yes, contract.
Yeah. Okay. So what will be the difference between, you say it is not fixed to chest wall and fixed to pectoralis major. What will be the difference?
Sir, pressing against the wall to taut the serratus anterior.
No, forget about serratus. What I am asking you is, what is the difference when it is fixed to pectoralis and not fixed to chest wall?
Anything in the final stage, you said differs.
Yes, sir.
Yeah.
If it is fixed to chest wall, the staging of the tumor changes.
No. How will you know that it is fixed to chest wall? Clinically, how will you judge that this tumor is fixed to chest wall?
Sir, on examination, muscle, it moves along with the muscle movement.
What are the
No.
muscles of chest wall?
But, sir,
What are the muscles of chest wall?
sir, pectoralis major, minor, serratus anterior.
What do you mean by chest wall?
Sir, intercostal muscles
How many
and
muscles?
serratus.
There are how many intercostal muscles are there?
3, sir.
3. Okay. So can you able to check that muscles? So you said contracting the muscles. Will you be able
Yes,
to
sir.
contract the intercostal muscles?
Yes, sir. On asking patient to take long breaths
No.
and
Rakesh, you are going in deep waters. Sir is taking you somewhere. The point here is that when you say it is fixed to chest wall, it means that it is not mobile even without contraction or anything of muscle. When it is mobile in a resting and becomes fixed, when you contract the muscle, it is fixed to pec muscle and not to the chest wall. Sometimes there can be a problem, but remember the difference. As such fixity without any action is a fixity to chest wall. Do you understand? When you do some action and it becomes immobile, it is fixed to muscle, maybe pectoralis, maybe serratus. So understand, what does this chest wall means? Rib and everything, when it is fixed to, it is a very advanced. That's what you want to judge. And in this patient, it is very, very important because your tumor size is 10 centimeters. Please continue.
examination of axilla.
Again,
No
the same
palpable lymph node in right.
Again, right axilla. Already you said axilla and nipple is, breast is normal.
Yes.
Okay.
Multiple hard fixed to underlying structural lymph nodes in left axilla. Pectoral, lateral, and posterior group of lymph nodes are palpable on left side.
These two sentences can be made a single sentence.
Go back. Sir, you were asking something? Yes.
No, these two sentences can be made a single sentence.
Exactly.
Yes,
The
sir.
middle
Yes.
sentence is of no use. Okay. So what is the other name of pectoral group?
So, rotors,
No.
Pectoralis rotus.
interpect.
This is a very basic elementary question, Rakesh. You are supposed to know this. There is no excuse for that. What is the other name of lateral group? You have written, that's why one you know that you have written subscapulary posterior. Same way, each has a group. One is an anterior, one is a brachial. Answer is right. So how will you know anterior group is involved? Here, one more point you have not written is matting is or fused nodes are there or not, which is a very fixed to what? Which underlying structure it is fixed? And which group? All groups are fixed or some particular group is fixed?
That I have not mentioned, sir.
If it is matted, will it be considered as a fixed or not?
Sir, it could be matted and mobile.
So then, if it is matted and mobile, you will consider it as an extranodal extension or within the nodal things. Why there is matting in a malignant node?
Invasion by tumor cells.
It
Invasion.
practically amount to the same thing. You should understand that point. Do you understand? What we are concerned is the extranodal extension is there or not. Because very difficult fixity, usually if it is there, it will be very difficult to judge. Matting is very early and you can judge it better. Right?
Yes.
What is approximately size of this mass?
Axillary lymph nodes, sir.
Obviously, we are talking of that.
Sir, largest was 1.2 by 2 centimeter.
That should be mentioned.
Yes, sir.
Right? You should mention, is there a one mass, more than one mass? You said there are three groups. So they are different or collectively one mass. This is an important point, right? You have mentioned these three groups. What about the other groups? Are they involved or not? Apart from these three groups, which are the other groups?
Apical group, sir.
Before that?
And lateral was mentioned.
You already
And
mentioned all the word. Central portion you have not mentioned.
yes, sir.
Central is the most important, I would say, right? So what is the other name of apical group? So you have to go and read a lot of anatomy, I think. That is it's known as intraclavicular. Okay, please, sir, continue. Next.
What is that? First, axillae means particularly you are putting or that any it's a mistake. Example axillae. AE is there. Any specificity for that?
Sir, bilateral
Again, the same mistake.
Check. Okay, go ahead.
Go back. It's okay. Go on.
Will you examine the spine? Which portion we examined?
Sir, thoracic and lumbar.
No, how do you examine?
Sir, patient in sitting position, I would palpate the entire spinal for tenderness, if any.
Where do you expect the secondaries to go?
Sir, if there is a distant metastasis and in breast cancer, first bone metastasis is to involve is lumbar spine.
No. Which part of the vertebra? Is it a body or the transverse process or where this goes? So depending upon that only you have to examine. If you are examining the midline, you may not see any tenderness.
Yes, sir.
You have to examine on the paraspinal region. It's on the transverse process. It comes. So examination is very important, not just putting your hand from above downwards in the midline. It takes long time to midline to be involved. The first on the other side you will get the second.
Again, you have made the same mistake. What is the purpose of third line?
Non-involvement of supraclavicular lymph nodes.
And what is the meaning of fourth line? Okay, let it go. Again, there is the same mistake. Next, I will have to hurry up now. Summary we have already discussed.
Yeah.
Go to diagnosis. Okay. So looking at your history, it definitely looks like a malignancy.
Yes, sir.
Okay. So now what will you do?
Sir, I would like to go with neoadjuvant chemotherapy.
Okay, straight away.
No.
You are so sure.
Sorry, sir. I would like to
How you will
investigate further.
confirm? Yeah. First confirm the
Yes,
diagnosis,
sir.
right?
Yes, sir. Yes, sir. Confirm the diagnosis.
So how you will confirm?
Sir, first I will go with USG radiological triple assessment, clinical examination, and history. After that, radiological investigation and histological investigation.
What radiological you will do in this case?
Sir, first line is all sonography.
47 years old.
Sonography. Why you like? What you want to see in a sonography? What are the indications for a sonography in a female pathology with the breast?
Sorry, sir, I couldn't hear you well.
Question is that in which conditions of the breast or which age group you will go for the sonography, and in which age group mammography?
Sir, less than 40 years, I will go for sonography, and more than 40 years, I will go for mammography.
So your patient is 47 years old
Yes, sir.
and a large breast. So
Signs of
ultrasonography.
signs of malignancy are here. You are yourself making a provisional diagnosis of malignancy. Then what you like to see on sonomammogram? And why do you want to go for it? Okay. You will go for sonomammography or mammogram?
Mammograms.
Okay, why? Because you are going to confirm it by some biopsy or something. So why you are going for mammogram? You can directly go for next step, that is pathological confirmation.
Sir, to look for any microcalcifications.
No, that
Which
is
are
what
better.
you are
How
not
is
diagnosing a mass. Now already you have seen a mass.
Yeah.
There's a thick mass, 10 centimeter. You think it is a malignancy. What do you want the mammography to confirm the diagnosis? Mammography will not confirm.
Yes, sir.
So bilateral
the
mammography is indicated for what?
What is the reason?
No, you don't take much time because if you do not know, say that, then we go to the next point.
Yeah. Rakesh,
Yes, sir.
do you know it or not? Then we will go to the next question after clarifying this.
Yes, sir.
Do you want to see, though it is a large mass, do you want to see something in the other quadrants? Or why you want to go do the mammography in the right breast?
So to look for if the other breast is also involved or not.
Yes, one thing is bilateral.
Yes.
There could be incipient or small lesion there. And second thing, it will serve as a screening mammogram for the dead breast in future, because once a patient of carcinoma breast, there is increased incidence of malignancy in the other breast. And in the breast with a lump, what do you want to see?
Sorry, sir, I couldn't get you.
No, you are here or okay. In the breast with the lump, white mammography is indicated.
To know the exact dimensions radiologically.
How it is going to help you?
In staging the tumor.
No, not for staging. You are partially right. For the volumetric assessment, you can do.
Yes, sir.
For chemotherapy, when you are starting a neoadjuvant therapy, in this case needs. And when you are going to assess the patient, whether he is a responder group or non-responder group, it can help you.
Yes.
If it is a small tumor mass, you can look for a multicentricity,
multicentric. So that is the main thing, multicentric or multifocal. That is the aim of your doing a mammogram, even in a suspected case or a confirmed case of malignancy.
What is a normal hidden area in the mammogram? When you are taking 2D mammogram, what is the hidden area?
So
the nipple and the retronipple area will not be seen much. So that is why now tomosynthesis or 3D mammography you have to take. Which
Yes.
view you will say be able to see the axillary node? In the mammography, which view you will be able to see the node?
Craniocaudal, sorry, sir, mediolateral oblique.
So there is another equation where, so already Kanavil sir is saying the time. Okay. So you do the mammography. Next, any test? You have done a mammography for this patient?
Yes, sir.
You have the picture?
Yes, sir. I have added the findings of the same.
Okay.
He doesn't seem to have images, sir. He has added the report.
Yeah, yeah.
Yes.
Okay. Okay. So any
Okay,
other
but-
physiology? That's all. No, you have not done any other investigation. Fine. Next,
Sir,
how do you confirm your diagnosis?
Sir, true cut biopsy.
Why you would like to do true cut biopsy? Okay. Can you do FNAC also? It
Yes,
is
sir.
less
Can do
invasive.
FNAC also, but I would
No, no.
prefer.
Why you will do both? You are saying I will do FNAC also and true cut also.
No, sir. No. I'll do true cut, sir. Directly go for true cut.
What is the advantage? What is the advantage of true cut over FNAC?
True cut tells us about invasiveness and about the hormonal receptor status.
Yes, that is
So
the main
that we can-
advantage. Because
Yes, sir.
if you are taking the patient for neoadjuvant chemotherapy,
Yes.
then you need a beforehand hormone receptor status. That is the one advantage of that. So true cut. FNAC is not suggested in any breast lesion if you're suspecting malignancy, especially in females over 40 years of age. Because sensitivity specificity of FNAC is also less than true cut or a core needle biopsy. What type of core needle biopsy is best?
Sir, no idea. I would
What size
update
of
Heard
the
of
chart.
vacuum assisted core needle biopsy?
Yes, sir.
So that is, if that facility is available, instrument is available, that is the best thing. But it gives you a quite adequate amount of tissue for diagnosis and hormone receptor analysis.
Yes.
What size needle you use for core biopsy?
Sir, we can use 18G needle.
Okay. So your what is the histology report you got?
Sir, post-operative histopathology report I had.
Sorry. What do you mean by post-operative?
Sir, she underwent modified radical mastectomy and histopathology report of.
Sorry, I think he's asking about true cut biopsy report.
True cut biopsy.
Yes, sir.
Yeah,
That report I don't have with me, sir. Right.
Okay. Okay, patient underwent MRM.
Yes,
Was it justified?
Yes, sir.
Suppose you are given choice, what you will do?
Sir, neoadjuvant chemotherapy first.
Why?
But it depends on surgeon choice, sir. We can go straight.
No,
for-
No, not in this case. Not in this case.
You
Definitely.
cannot say this, don't answer like this surgeon's choice. It's a malignancy. We are talking of the protocol, not the technique
Yes.
of doing a surgery, right? So don't
Yes,
give
sir.
this answer that it is a surgeon's choice to go. What should be done in this case?
Sir, neoadjuvant chemotherapy first.
First, why?
To downstage the tumor.
To downstage the tumor, or what is the principle behind giving a neoadjuvant therapy? Now it is moving even in the stage 2.
After chemotherapy, when you are staging the breast, what will be the stage of the breast?
It will change, do you think? Or you will write differently then?
You have done a neoadjuvant therapy, the tumor has come down, all that size has reduced.
Yeah.
Will you change the staging?
So in your file notes, you will change the stage?
Original staging is still
Remains the same, yeah. So what is the advantage? What is the principle behind giving a neoadjuvant therapy? Just we have to finish the case, so please be quick.
Okay.
Okay.
Please
But
note
you will
the
prefix
pathological staging has come as a N3A.
Okay. If the
There was one
chemotherapy-
more question I want to clarify, sir. would you like to take a true cut from axilla also or not? Will you do FNAC in axilla?
FNAC in axilla.
FNAC in axilla, sir.
You will do?
When you are giving the patient a neoadjuvant chemotherapy,
Yes, sir.
if you have to stage that, then you prefix Y in that, okay?
Yes.
Like we say is a CTNM, PTNM,
Clinical, yes.
it
Yes,
becomes
sir.
YTNM, okay?
Yes, sir. Yes.
YTNM means now the stage has changed from the CTNM to YTNM now, okay? After the chemotherapy.
Yes, sir.
No, at the end, the stage is N3A. You are clinically N2A. What is the difference?
Sir, fixed lymph nodes is N2A and
That is what the
each-
question was asked. Because earlier it will be matted nodes. This also comes under N3A.
Yes, sir.
So you must be careful whether it was a single node or the fixed. Don't think it's just fixed is only the fixity. Even if it is a matting is there, you should put that. That is what pathologically they are putting it as a N3A.
Yes, sir.
Rakesh, before ending, I think already one case is left. Can you answer this important question? Why neoadjuvant therapy? Last question. This is I asked you. So let me. Hello, Rakesh. Could you
Yes,
hear
sir.
me?
Yes. Yes,
Please
sir.
go ahead.
Okay. If you do, okay. Then the main advantage is that according to Fisher's hypothesis, that it's already a breast carcinoma is when it presents as a lump, it is already a disease, systemic disease. Right. So main
Yes,
purpose of neoadjuvant chemotherapy is to control the systemic spread, that is metastasis.
Yes, sir.
And second advantage is that you can see the response of the chemotherapy.
Yes, sir.
Because after MRM, when you give a chemotherapy, the lump is already gone. There are no parameters, clinical parameters to check whether the drug is tumor is responsive to the drug or not. In the neoadjuvant therapy, when you give a drug and you see the response to the tumor, if it is not responding, you can change that drug, which can be followed, continued after the surgery. So these are the two very big. Second one is also very big advantage of neoadjuvant chemotherapy, that you know the prior sensitivity to which group of drugs this tumor is sensitive.
Your anterior margin is positive, post-surgical, the margin is positive.
Yes, sir.
What you are going to do for this?
Sir, the anterior margin was the skin only, sir. So already the lump tissue has been removed.
No, is that? No, nobody will give like that report. The anterior margin positive means the skin, the report is given us like that.
Skin was involved.
So, but that part was removed, na?
Yes, sir.
So margin positive means?
Margin is only they are talking about, not the center portion.
Yeah.
That means you are not adequately removed the skin.
Skin.
So the gross specimen which we have submitted to the pathology department, it also included the skin. So anterior margin.
That is what they are saying, the margin of the skin, not the center portion of the skin. The margin is free means, not free means there is some more cancer is there in the other rest of the skin which you are not removed.
Yes, sir.
So what is how do you manage that case?
Sir, to avoid these mistakes, intraoperative process.
Not a mistake, but now it has been done. The report is coming.
Yes.
What is your option now?
Sir, radiotherapy. Sir.
Okay. So, or we will go for resurgery.
Sir, no, sir, radiotherapy.
So that is a difference you must know. If it is a BCS, if the margin is free, margin is then your option is going for a resurgery.
Yes, sir.
But not the resurgery here.
Yes, sir.
Okay, because time is up. 9 minutes more. Kanayvel sir, you can take over.
Yes, sir. Rakesh, do you have any questions or doubts to be clarified?
Sir, no, sir.
Professor Erbas, sir, do you have any questions, sir? Sir,
all the questions and the topics have been covered really well, sir. So I was there all throughout, and it has been he has tried to present And as what the other examiners have made a point that it has to be simple. Extra information is going to be detrimental to the presentation. And we have a limited time during which we have to assess the students. So if they can make things simple, it becomes easier for us to go to more the deeper questions, which would give them more marks. Like say, for example, in this one, we haven't been able to discuss the entire treatment because it took a lot of time in the presentation of the case.
I get your point.
Thank
sir.
you for your valuable input, sir.
Yeah.
And with the permission of the faculty, I thank Dr. Rakesh and Dr.
Thank you, sir.
Sachin Jama sir for giving this discussion case for the discussion. And now I move on to the next case discussion. Archana from Coimbatore Medical College. Can you unshare your presentation, Dr. Rakesh? You stay back for the discussion.
Yes, sir.
Dr.
I'm
Archana?
staying. I'm staying.
Yeah, yeah. Yes. Dr. Archana, are you with us?
Yes, sir. Good evening, sir. Good evening, all
Good evening,
faculty.
Dr. Archana. You should adjust your camera, ma. I think it is little steep. Make it perfect. Now it is perfect, right? You start your PowerPoint, introduce your unit chief, and then your head of the department and start your presentation. Good luck to you, Dr. Archana.
Thank you, sir. Good evening, everyone. I would like to thank Professor Dr. Srinivasan, sir, who's been the guide for this presentation, and our department HOD, Dr. Lakshmi Narayani, ma'am, and our Chief Dr. Associate Professor Dr. Jayakumar MS, and our Assistant Professor Penile, ma'am, and Balamurikan, sir. Now coming to the case presentation. My patient is a 60-year-old male from Erode, a manual laborer by occupation, came with chief complaints of ulcer over the penis for past 2 months. History of presenting illness, he presented with complaints of ulcer over the tip of the penis. Initially started as a small bleb 2 months back, which burst and progressed to achieve the present size. Ulcer was associated with foul-smelling discharge, which was noticed 1 month back, for which he has underwent treatment outside. He has a history of dorsal slit biopsy done outside 10 days back. There is no history of fever or pain, no history of difficulty in passing urine or pain while passing urine. There is no history of recent onset phimosis. There is no history of penile trauma. There is no history of high-risk behavior. There is no history of swelling in the bilateral groin. There is no history of loss of weight or loss of appetite, or no history of breathlessness, cough with hemoptysis, bony pain, or jaundice. Past history, patient has no known comorbidities and he has no history of any previous surgeries. Personal history is not a known smoker or alcoholic. He has got a normal appetite and normal bowel and bladder habits, and sleep is also normal. Family history, there is no significant family history. Family, a 60-year-old male with complaints of painless ulcer over the tip of penis with no associated complaints, with history of dorsal slit biopsy done outside.
You are asking the history on the urination and difficulty in maturation. Is there any significant on this?
Sometimes in case of precancerous lesion like BXO, there will be meatus stenosis for where he can have difficulty in passing urine. In case of phimosis also, he might have difficulty in passing urine.
You already said there is no phimosis, no?
No.
That is all.
Dr. Archana, could you go to your first slide, please?
Yeah.
Okay, next. Okay, why was the dorsal slit done? Just go back, please.
He had no history of difficulty in passing urine, but it was done outside, sir. He told there was biopsy was done by taking the skin of the prepuce, gave history.
Okay, now let's forget what it was done outside. Why do you think, suppose a patient came to you with this kind of a problem, what would be the indication for doing a dorsal slit?
If there is presence of phimosis, sir.
If he's
Oh,
not able to, phimosis, he would be there. That would. If he's unable to pass
unable to
urine,
pass urine and unable.
Yeah.
right?
But
Yes, sir.
here, Dr. Archana, you see, the ulcer was at the tip of the penis.
That's a glans penis or prepuce?
Both involving prepuce and glans penis, sir.
So that is not
Prepuce and glans penis. But,
Initially at the tip,
but,
sir. After that, it progressed to involve the entire glans penis and prepuce, sir.
okay, that is right.
no, then we have a question comes because you said there is no phimosis, but somebody is doing
Yeah.
dorsal slit.
Yes, sir.
Dorsal, they are taking a biopsy
No
from
need
there.
for ground phimosis, no need for doing a dorsal slit.
Yes, sir.
Dorsal slit.
Okay.
So it started with a small bleb. What do you mean? It's
A small,
It was a
no,
cyst.
he told small vesicle, cyst.
Okay.
Do you think the malignancy will start like that?
No, sir. It could
What is
be.
the usual presentation of carcinoma penis? What is the lesion? How it is described?
It's a
Bleb is not a description for that.
papular plaque.
With nodule, exophytic growth, ulceration, erythema, even induration.
Yes.
Right? And you
Yes, sir.
just carrying from the previous case, I would like to add one thing, the fungating lesion. There is a definition by the National Institute of Health of the fungating lesion, that is ulcer associated with necrosis and a foul smell. They have defined in their cancer site that this is the meaning of the fungating lesions. What are the other malignancies which present as fungating lesion, which can present? Usual presentation.
Basal cell carcinoma.
No. Squamous cell carcinoma,
Squamous
melanoma,
carcinoma.
and melanoma also, and
Melanoma.
breast carcinoma. These are the three common malignancies which can present as fungating lesions, right? Okay.
So total duration is only 2 months or what?
Total duration is 2 months, sir. But from 1 month back,
He had a very foul smelling ulcerated lesion.
Yes, sir. For which he underwent treatment outside, sir.
This looks very, within 1 month you started the bluff. The bluff immediately becoming a big ulcerated lesion. No, do you think that transformation, that such a fastly growing tumor you will get in a carcinoma penis?
No, sir. It's usually slow growing, sir.
Okay, so there is something you are not asked the history. You are taken the history in the superficially. You are not exactly taken the history properly, because otherwise this mistake of dorsal slit, no phimosis, there is a huge false smelling discharge. It's not fitting into your description. Okay, go ahead. Next slide. Penile trauma.
Why you have taken this history?
Ulcer.
Ulcer is not
it is a traumatic ulcer, you mean to say?
very, very rare to get a traumatic ulcer in the penis. Okay. High risk behavior, and what is the relationship of high risk behavior and malignancy?
So history of smoking and multiple sexual history of smoking has a predisposing increased risk factor for carcinoma penis. Multiple sexual partners have increased risking HPV infection, which can lead to carcinoma. It's increased risk in carcinoma.
So HPV is a sexually transmitted disease. You think HPV is a sexually transmitted disease?
Yeah, yes, sir.
So all the people with the carcinoma cervix will have their husband.
No, sir. No, sir. It's most of the HPV infection is eliminated by our host immunity. If there is a repeated micro trauma to the epithelium will cause.
Okay. So you asked for the bony pain. Which bony pain?
Sir, back, vertebral and yeah.
So carcinoma penis is a squamous cell carcinoma. It will go to the vertebra. Invariably, squamous cell carcinomas, loco-regional.
Yes, sir.
Not like what we
Hip, pelvic,
are saying the
pelvic.
Weiser concept is not going to there. And what it will put is osteolytic lesion or osteoblastic lesion?
Also, lytic, sir.
Lytic. Oh, normally not. Oh, okay. Go ahead. It's very don't make this a routine asking that unless you know for what you are asking, why you are asking. Otherwise, don't just for the routine's sake, don't put bony pain, other things in the carcinoma penis when you are asking for this.
Okay.
Yeah, and Archana, you're taking the history of sleep pattern normal. Is there any significance in this type of complaint? You're asking a sleep pattern of a patient.
No.
So in the previous case also it was mentioned, don't take unnecessary history which is not related to the complaints, right?
Okay.
Sleep normal is an important history in a case of chronic liver disease, but not in a case of penile lesion.
Yes, sir.
Okay.
Yes, sir.
Next. Family history nil significant. Oh, yes. How many children he is having?
He's having one son, sir.
Okay. Go ahead.
General physics.
Time we have, so you can go first.
Okay. General physical examination. Patient is conscious, oriented to time, place, and person. Moderately built and nourished. ECOG 1. Hydration fair. No pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, or beta edema. Patient's vitals were pulse rate 88 per minute, regular, normal rhythm and volume. BP is 110 by 70 millimeter mercury on right arm sitting position. Respiratory rate is 16 cycles per minute, and he was afebrile at the time of examination. On inspection, local examination of the penis, inspection, ulcer-proliferative growth of size 3 to 3 centimeter involving glands in the coronal circus and prepuce with irregular shape was noted with irregular shape, irregular margins, everted edges, and floor covered with necrotic tissue. External urethra meatus was visualized and is in normal position. Rest of the penis and scrotum was appearing normal. On palpation, the lesion was not formed, no tender. Ulcer-proliferative size of 3 to 3 centimeter present over the glands, penis, and prepuce and coronal surface with irregular surface, irregular margins, everted edges, floor covered with necrotic tissue. Base is indurated and confined. The induration was confined to the glands, penis, and the prepuce. The rest of the penis was normal on palpation. Scrotum, bilateral testes, and core structures were normal. And on right side inguinal region, there's a small, firm, mobile, non-tender lymph node was palpable, which was around 1 into 1 centimeter. Digital rectal examination, there was no palpable mass. There was fecal staining. Normal fecal staining was present. And there was no prostatomegaly. On systemic examination, cardiovascular system, both hearts were, there was no murmur. Respiratory system, there were no added sounds. Bilateral air entry was present. On abdominal examination, abdomen was soft. There was no tenderness, no mass palpable. There was bowel sounds present. On summary, it's a 60-year-old male with painless ulcer-proliferative lesion over the distal penis with no other associated symptoms, with history of dorsal slit biopsy done. And also there is an ulcer proliferative growth. On examination, there is an ulcer proliferative growth involving glands, coronal circus, and prepuce with irregular shape margin and everted edges covered with necrotic tissue and indurated base with palpable, firm, a mobile, non-tender right inguinal lymph node. Diagnosis.
Go to the inspection slide. Are you the picture and your inspection findings are not correlating? You said ulcer-proliferative lesion of 3 into 3 centimeter. Where is the lesion?
Sir, this is a small ulcer with surrounding full lesions of a necrotic tissue and indurated base is there, sir.
This looks like a necrotic tissue on a picture. It's only like a scab or something is covered there. We are not able to see ulcer-proliferative lesion. Is it a circumcision done or only dorsal slit done?
Sir, only a part of the prepuce is being taken, sir. Not full circumcision. Sir.
Okay. So which is an ulcer area you're saying?
Here there is an ulcerated area.
3 into
sir.
3 centimeter.
I said here also there was a mass there. This here also. So I taken the whole. On palpation there was a mass there.
And you said everted heads. Where is everted heads?
Sir, here.
That is not everted. No? Everted means it crosses, overhangs the margin. Don't just write what as per the squamous cell carcinoma with the everted heads. If you are seeing the case, because examination, we are going to see the case and we are going to hear from you.
Mm.
And if there is no everted margin, just say there is an ulcer. 30 to 40% of the carcinoma penis or squamous cell carcinoma can present without everted margin. It is not mandatorily that all case you should have everted margin. So when you are saying, describing an ulcer, because that is very fundamental of a postgraduate to describe an ulcer, and where you are making a mistake, necrotic tissue is there, which we are not able to see on the picture. So you describing the ulcer should be in as per what you are seeing on the case, not on your theoretical knowledge. Okay. And the palpation, you said induration, you are able to feel in the glans penis. How did you feel
Around the
induration?
glans penis, entire glans penis was indurated along with prepusor.
What do you mean by induration?
So the base was firm and indurated, sir.
Glans penis, you are able to make out that.
There was induration in the base over here and the prepusor.
Oh. It's very difficult to make out the induration in the glans penis. An ulcer is there like that. And the next slide you are putting as a no warmth. Which portion is not warm?
There was the penis and surrounding area was not.
You are talking about an ulcer.
Sir.
Ulcer is not warm. You made out the warmth of the ulcer.
Surrounding area was not found.
You must be specifically say,
Mm.
just may not warm, not tender. How did you assess the warmthness of the penis?
Is that the
Compare with what?
normal
Normal what?
normal skin, sir?
Which skin?
Surrounding skin, sir.
Okay.
Okay, Dr. Archana, you have written distal rectal examination, no mass palpable, right?
Yes, sir.
Why do you want to do this examination in the case of penile ulcer? What do you expect?
Any pelvic masses or
Pelvic
prostate,
mass is, do you think a pelvic mass is a feature of the carcinoma penis?
no, sir.
Where is the metastasis of the carcinoma penis?
Lymph
Can
node,
Lymph nodes and then lung, liver, bone, and brain.
yes,
So
sir.
they are not dropped metastasis like we see in gastric carcinoma or sometimes maybe in the breast carcinoma. So
Prostate,
simply, yeah, so it's not necessary, I think. There is no
Any
history.
node you can palpate through the rectum?
sir.
Any node you can palpate?
Anything.
Any node which is coming in relation to the carcinoma penis, you can be able to palpate.
Iliac.
What is the gateway node? If that node is involved, that means there is a pelvic node is also involved. Especially the glans penis ulcer.
Clocket.
Without inguinal node, it can directly go to the clocket node.
Yes.
What is the importance of identifying the base?
We have to.
It is confined to the glans and prepuse, you said.
Yes, sir. We have to give a margin from the induration. The resection margin should be from the induration, extension of the induration.
So that is important. That is why you have to be very careful in finding out a induration in the carcinoma penis. So that is going to give you the margin it is calculating based on that. Oh, next. What is the stage?
Sir, clinically T2, sir.
Why T2?
It's a glands induration
T2.
spongiosum.
Hmm?
Sir, actually,
T2
it
is
could be T1 or T2, sir.
No, what do you feel?
T2 is stage T2 is at sorry 2.
T2 is involvement of corpus spongiosum, sir.
Yeah.
So it's involving the glands and papules and
In
extensively
your case,
so.
it is the dorsal surface.
Yes, sir.
Yeah.
You get the spongiosum.
Sir, ulcer is in the ventral, sir.
There is no evidence to say that it's a spongiosum. Is involved.
Spongiosum, yes, sir. Biopsy, I have to do a biopsy.
What is the differential of this? What could be the other lesions which can present
Ulcer,
as a ulcer, penile ulcer?
it could be inflammatory, which could be syphilitic ulcer or Hungarian Schanger.
Yeah.
Primary
Syphilitic,
mixed syphilis.
syphilitic.
Second
It will occur in primary syphilis.
this
Sir.
ulcer, this looks
No.
like ulceroproliferative growth in the primary.
No, sir. Primary syphilis ulcer will be a button-shaped small ulcer, sir.
But
It doesn't look like that.
No, sir.
it doesn't look like that.
So can it be
then-
secondary syphilis? No, what is condyloma lata? What is
Later,
Yeah.
Condyloma acuminata.
what is the difference?
Condyloma acuminata is caused, it's a warty lesion, or also known as genital warts, caused by HPV infections. Yes.
Yes.
Well,
Buschke Lowenstein tumor.
2%. Correct.
What are the other pre-malignant lesions for the carcinoma penis?
It could be HPV related and non-HPV related, sir. HPV related include condyloma acuminata and bovinoid papulosis, while non-HPV related skin lesions include balanitis sclerotica obliterans or lichen sclerosis of penis, leukoplakia of
Okay.
penis, and
Right.
cutaneous horn of penis, and micaceous keratotic lesion of penis.
But this presentation is different, so they may not come into the differentiation because there is scaling and that thing is not here. It is matters changes, leukoplakia, whitish discoloration with fibrosis. Yeah. So you can just keep your first diagnosis as good as this carcinoma penis, right? Though there are no lymph nodes. How many percentage of patients of carcinoma penis present as inguinal lymph nodes in their first presentation?
It's low, sir, because 50% of the cases could be.
No, I'm talking of presentation. I'm not talking of whether they are metastatic or whether they are inflammatory lymph nodes.
I don't know the percentage.
So around 50% of the carcinoma penis
50%.
patients, they present with palpable lymph nodes, right? And that is a separate issue whether they are having a metastasis or they are inflammatory due to infection there. Okay. So what you will, and you have mentioned one time also no generalized lymphadenopathy,
Yes, sir.
right?
Yes, sir.
So what is the lymphatic spread of carcinoma penis?
First, it will go to the superficial inguinal lymph nodes. It follows a sequential pattern of drainage. First, it will go to the superficial inguinal lymph nodes, followed by deep inguinal lymph nodes, and then to the iliac nodes, and then paraiotic and retrobeta.
So usually the iliac and it will not be palpable until unless they are very large, right?
Okay.
So no need to mention generalized lymphadenopathy.
Okay.
When you mention a term generalized lymphadenopathy, you are mentioning for the diseases which present with generalized lymphadenopathy, like Hodgkin's, non-Hodgkin's, leukemias, right? Okay. So how will we proceed with your case?
Sir, I would first like to confirm the diagnosis. There has already taken the dorsal slip biopsy. First, I would like to review the biopsy.
But what you are
And-
expecting in the biopsy? Can you tell the histological features?
Yeah.
Sir, the report, sir.
Hmm.
The report
Yes.
shows features of varicose hyperplasia with varicose carcinoma along with extensive ulceration and granules.
Verrucous carcinoma. So that your picture and your ulceroproliferative fungating lesion is not correlating. Then verrucous carcinoma will not go for a fungating lesion. It is only verrucous hyperplasia, verrucous carcinoma. Exactly, it is looking like not like a very ulceroproliferative lesion. Okay.
Yeah.
So
I
we
would
are
like,
going to proceed now.
sir, superficial varicose carcinoma is considered as TA, sir. So,
Yeah. Can
That
you
is
repeat,
different,
please?
entirely different. TA is non-invasive superficial.
Superficial.
Yes.
That means your lamina propria should not be involved.
Okay,
So
sir.
here it is not varicose carcinoma, you will get involved.
Okay,
What
sir.
other carcinoma you will get
But-
TA, no? The whole of
Yeah.
TNM classification.
Yeah.
Do you remember any other carcinoma you get a TA lesion?
Varicose carcinoma.
No,
No.
no.
Verrucous
Try
carcinoma.
to understand the question.
No, sir.
Squamous cell carcinoma. Usually we got TIS something good, then
Yeah,
TU.
yes, sir. No,
But here
TA
it
is no,
is
sir.
a TA, non-invasive squamous cell carcinoma. So similarly, there is only one carcinoma, there is another lesion, there is a TA comes. It is in the bladder carcinoma.
Okay.
There in the bladder TNM also, you will get a TA. So
Okay,
here
sir.
there is a TA is there. So
So
TA,
I would like to stage it, sir.
No, Dr. Archana, one more question.
Oh.
What is varicose carcinoma? How it is different from squamous cell carcinoma?
Varicose carcinoma is mostly locally aggressive and it has got less lymphatic. The risk of lymphatic drainage is low, very low. It is also known as the giant condyloma accumulata or Buschke-Lowenstein syndrome caused by HPV virus.
No, it is a variant of squamous cell carcinoma.
Square
It is-
carcinoma.
Yeah.
what
And
actually
the histopathological examination, what
Well
is the difference?
differentiated.
Yeah, what is the difference between squamous cell carcinoma and varicose carcinoma? Though
Varicose
it is also
carcinoma. Varicose
mainly caused to be
carcinoma.
the
Well,
HPV.
Yeah, what is the difference between the margin of these two type of carcinomas?
they are more superficial. Varicose carcinomas are more superficial, sir.
No,
They are
have a
more well differentiated. Well
they are
differentiated.
well demarcated margin,
Well
while squamous cell carcinoma, classical squamous cell carcinoma have an infiltrating margin.
differentiated parts.
Yeah.
So suppose it is a varicose carcinoma, if it is a first surgeon who has done a dorsal slit, if he has done a circumcision,
Hmm.
do you think that would have been the sufficient for the patient for varicose carcinoma?
But the glands had a ulcer, sir,
Yeah.
so
Right.
that will not be. It is not confined to prepuce, sir, so it is not.
I still doubt that the gland ulcer is a malignancy. You said it is a bluff. You started, it have been something else. Because that doesn't looks like a malignant ulcer in the glands. Okay, because this looks like a varicose carcinoma, because if it is a circumcision, it should have been done fully. That have been the sufficient for that.
Hmm.
So how will you proceed now? Varicose carcinoma, you are having no doubt on the histology, no?
No, sir.
Or you are going to take a biopsy from the glans penis?
Sir, there is no information regarding depth of invasion or lymphovascular invasion.
What is the need for you to know depth of the invasion? Depth of the invasion is only in a oral malignancy. Carcinoma, you need a oral depth. In a squamous cell carcinoma, here in the depth is not going to give you. That is going to be by the MRI. If you want to see, are you going to take a spongiosa out and going to check the histology?
So I would like to stage.
So what you will do for staging?
For nodal status, I will do an ultrasound check because already he has palpable lingual lymph node.
No, Baba, here T stage
No.
itself, you said you have a doubt, no?
Yes, sir.
So how will you confirm that?
It's surgical.
What is the role of MRI?
MRI, if the lesion is unequivocal, we can do MRI penis to see the extension of the
Precaution
lesion.
you will take, or what is the instruction will give? Take the MRI penis.
Yes.
No. When you are advising MRI penis, what else you will be telling the patient, or what will be the mandatory to take the MRI? It's not a flaccid penis; it should be an erect penis
Yes, sir.
to take an MRI.
Okay.
The flaccid penis will not; they will not take the MRI.
Okay.
So MRI is mandatory because you
Have
in
doubt in it.
T1 also T1A B comes. B is a lymphovascular invasion or the perineural invasion is there. So all that can be made out by your MRI. If it is a good MRI, can tell you that. Because there is a difference between T1A and T1B.
Yes, sir.
T1A, it is only a
Yes.
surveillance.
Low.
T1B, definitely you need to look for the lymph node.
Mm.
So MRI is mandatory for this case. You will do MRI.
Yes, sir.
So now MRI is normal. It is confined to the glans penis and the prepuce. What is your-
If it's T1A, sir, we can directly go for we can provide a organ sparing surgery like
Before that, you have to check your node, no? You said there is one node is palpable.
yes, sir.
What do you do? with the node?
Ultrasound of the first ultrasound of the inguinal region, followed by FNAC.
Why ultrasound?
No.
You have a palpable node is there.
Yes, sir.
And you want to do an ultrasound there.
What
If
you may
any
do?
bilateral.
No. What used to be done initially, as you yourself discussed, that all these lymph nodes are not metastatic lymph nodes. In the early lesion,
We can give
what you can do if there are few palpable lymph nodes?
In early lesion, we can give prophylactic antibiotics.
Yeah, give a course of antibiotic and then see for the regression of the lymph nodes whether it is present or not. Right? And before that, whether
one
you would like
school
to
of
go
thought,
for
now you are doing it
That-
simultaneously. That is, previously we used to say there is a 4, we can wait for that. Now you can do an FNAC.
Yeah. So
FNAC can give you that. If the FNAC is not there, positive, you can do an excision.
Any biochemical test apart from the radiological investigation like X-ray, CT abdomen to stage the disease?
SPC, LFT, liver function test.
Okay, that is in the liver metastasis. Anything more which is increased in around 20% of the patients, even who are not having osseous metastasis.
Calcium and
Yeah, very
serum
good.
calcium.
Calcium hypercalcemia is found in lot of these carcinoma. What is the reason for that?
PTH, increase in parathermone.
Not increase in parathormone like peptide.
Peptide.
That leads to increase in hypercalcemia. Okay, right. So how you will manage this case, no? It's like surgical management or whatever you like to do.
Sir, if it's a T1 A lesion with low grade with no lymphovascular invasion, we can go for a organ sparing surgery, which could be where we can organ sparing surgery, which could be Mohs microsurgery or laser excision or gland wide local excision. In case if it's only prepuce circumcision.
No, but in this case, it is your
Involving the
glands.
glands. So partial penectomy can also be.
Only partial penectomy. Anything less than that?
A glandsectomy.
Glandsectomy can. If you are confirming that it is an ulcer, is again from the glans penis. Can it be erythroplasia of Correct?
Correct.
Erythroplasia cureate is a reddish plaque. It
It
looks more
looks like a reddish
like
only.
reddish plaque. Yes,
What is
plaque
the
more
which cannot be.
Bhavans and
grayish, yeah.
erythroplasia of Correct?
Erythroplasia cureate is the reddish plaque present in the glands, and it's present in the. It's a carcinoma in situ of present in the glans penis. When it's present in the shaft, it is known as the Bhavans.
What is the common site of Bhavans carcinoma, Bhavans tumor?
A shaft.
The shaft Bhavans can present, but Bhavans common site is not shaft, not in the penis. It is the sun exposed
sun exposed area.
axilla. What is the difference between Paget's and Bhavans?
Paget's disease is its presence is eczematous lesions, which is due to underlying adeno
This
carcinoma.
Paget's disease, extra-Paget's disease, extramammary Paget's or Bhavans, all are cutaneous manifestation of the underlying malignancy.
Underlying.
Bhavans and erythroplasia cureate is a squamous cell carcinoma. Paget's is for
In situ.
adenocarcinoma. So all that is same. So this lesion could be, if that is an early lesion, any other chemical methods, any drug is useful.
So topical 5-fluorouracil or imipimod can be used.
How much?
Dose 5%.
5%. How long? When? Okay. You said mock surgery. What do you mean by that? In the verrucous carcinoma, will you do a mock surgery?
We can most surgery is done in T1A lesions. Multiple slices have very thin sections have been taken, and until the negative margin is.
You said verrucous is locally malignant.
Yes, sir. No,
So
sir.
early lesion of the squamous cell carcinoma, you will have a much good result than in a verrucous carcinoma.
Yes.
So any other treatment you want to give? What do you want to do for this patient, your patient?
I would like to do a.
Patient says, I don't want any surgery.
We can, if it's less than 4 centimeter, we can give radiotherapy, sir.
No, more than 4 centimeter, no radiotherapy.
It's usually done. It is there, sir. In T2 and T3 also radiotherapy is being.
T1 lesion can be itself more than 4 centimeter.
More than 4 centimeter. Yes.
T1 can be also
Can
more
be
than.
also more than 4 centimeter.
Both can be given radiotherapy. What is the difference? If it is less
Better
than 4 centimeter, you can give a brachytherapy.
That.
You can give a mold. Iridium can be given. If it is more than 4 centimeter, you have to give an external beam radiation.
External beam therapy.
So that is the only difference of the size which is there. So, but if the patient is not willing for surgery or it is a organ conservation you want, you can still go for a. So is it a radiotherapy or chemoradiation now you are saying?
The radiotherapy.
Now always into the chemoradiation.
Chemo. Okay.
Yeah,
So that is
neoadjuvant chemo followed by radiotherapy, and if completion surgery can also be added to it after regression of the site.
It's a common chemotherapy used.
TIP regimens are paclitaxel, ifosfamide, and cisplatin.
Suppose the node is, you said one group node, if this FNAC is positive. FNAC source, there's a node is positive, what do you do?
Sir, we have to do ipsilateral inguinal dissection, sir. Inguinal node dissection.
What is the indication to proceed with the pelvic node dissection?
If there is more than 4 positive lymph nodes, or if there is an extra nodal extension present, then we have to proceed with in iliac.
There is a 4 node and extra nodal, that is an indication for bilateral neck node dissection.
Pelvic node.
So if there is 2 node is positive, if you are giving 2 node is positive, or if you are seeing cloaket node is involved, then definitely you should go for a
pelvic node.
What is the boundary for doing your superficial inguinal dissection? What is
sir, medially lateral border of the adductor longus, laterally medial border of the sartorius, superiorly 2 centimeter above the inguinal ligament, lower is the apex of the femoral triangle. Sir.
So now what is the surgery is preferred? You prefer the trussless quadrangle or any other surgery? What is the modification?
Modification is Catalano's modification, sir, where we will take up to only fossa ovalis, is the lower boundary set, and lateral boundary is femoral artery set. Medially, it's data longus set, and all the lymph nodes present in the superficial to facial lata is being taken in that triangle set.
Suppose we
and
want
there
to
is GSP is paired, sir, and sartorius transposition is not done, sir.
So which group of lymph node is involved here?
Horizontal,
Horizontal, which group?
medial,
Superficial or deep?
superficial.
What is Cabana node?
Cabana node is superior medial nodes in group in Dressler's classification, sir. Superior medial group of
What's prognosis for this patient? How you are going to maintain this patient?
surveillance, sir. Surveillance for early cancer, every first 2 years, every 3 months, clinical examination and surveillance should be done, sir. And next 2 to 5 years, we have to do every 6 months. Next 2 years, every 6 months. After that, till 10 years, every year, sir.
What is the indication for total penectomy?
Total penectomy is done when we can't, there is no adequate stem after giving a negative margin, or when there is involvement of adjacent structures
No. What do you mean by inadequate stump?
less than 2 centimeter stump.
No. When there is insufficient length for
Stump.
sexual function and
You avoiding
proper stream of the urine,
Yeah.
right? Then you go for the total penectomy. Otherwise, you have to take partial penectomy 2 centimeter margin.
Yeah.
Right. Okay. What are the other malignancies of the penis? Other malignant histopathological types.
Adenocarcinoma can arise from Tyson's gland. Basal cell carcinoma, malignant melanoma.
Yes.
Sometimes secondaries can.
And recently, increasing incidence of which histological type of carcinoma penis? Penis malignancy. Kaposi sarcoma. Yes, right.
So how will you
What is
reconstruct?
the? Yeah, please, sir.
No, you can. How will you reconstruct the penis?
Penile reconstruction, pre-flap using radial forearm flap, or my osseous forearm osteocutaneous flap has been tried, sir.
So you said adenocarcinoma, no? Arising from where?
It's a Tyson's gland, sir.
So what is extramammary pages disease?
Extramammary pages disease arises from the it's the cutaneous manifestation of apocrine adenocarcinoma in the skin of.
And it comes in the penis?
It's a pages disease. Yes, sir, it can come.
Arising from the litters gland. Tyson gland.
It can.
Archana, what are the complications of inguinal block dissection?
Flap necrosis, seroma, lymphedema, lymphoria, surgical infections.
So how will you prevent the flap necrosis?
By using a smaller incision, thicker flap, including the fascia scarpa, superficial subcutaneous fascia scarpa also in the flap. Then usage of minimal cautery and
anything specific on the dressing?
Sir?
Dressing? Putting very tight dress or when you are putting a bandage?
No titers.
What about the types of the incision which can prevent the flap necrosis?
Horizontal incision, sir. 2 horizontal incision, 4
Two.
centimeters apart from inguinal ligament.
Can we use any other technique for carrying out the block dissection?
Lacy S incision.
Hmm?
Lacy S incision.
No, I'm asking any other technique for carrying out the block dissection.
Other than open surgery, any other technique you have?
There is minimally invasive using laparoscope. Laparoscopic has also been.
After the laparoscopy, what has come?
I don't know, sir.
Robotic surgery, na?
Yes, sir.
Okay. So everywhere where there is a laparoscopic surgery there is a robotic surgery is also there.
Yes.
Right. Now, how will you prevent the lymphoria from this patient? And what is the treatment of the lymphoria?
By superficial by the dissection above the tensor facial lata, preservation of GSP.
Using less of the cautery, ligating the lymphatics.
Any metals or any materials you will keep?
I don't know, sir.
There's no glass beads are coming.
Okay, sir.
So they say that it is possible. That's reducing.
If a patient develops the lymphedema, then what can you do for that?
I don't know, sir.
You can initially, it is always a conservative treatment.
Yes, sir.
Okay, you have to apply the Jobs pump, which is there.
Yes, sir.
Elastic bandages, which are there. You have to prevent any infections. So these patients, they usually are kept on the long-term Penile.
Okay.
Long-term penicillin is given to these patients to prevent them because that is the lymphoadenitis is there. That is one of the cause for the lymphedema.
Yes, sir.
Long-term penicillin is given. And then you can do the various types of the bypasses. You can do a nodal bypass, lymphatico-nodal bypass, you can do a lymphatico-venous bypass. And then there are certain types of the tubes which are the thoracic tubes which are there, which are used also for the lymphedema. So there are so many options which are there once a patient develops the
most needed the prevention is infection, control of infection by many means. Avoiding compression on that area, putting a
preoperative antibiotics.
Any role of orchidectomy in case of CA penis?
No, sir. Usually not done, sir.
It was done once in a time, no? Long people used to do.
Yes, sir.
Because once you do a perineal urethrostomy, there is a scrotum will go for excoriation.
Yes, sir.
So, yeah, that is the only indication for carrying out the orchidectomy in a case. So large scrotum is there and you are doing a perineal urethrostomy. To prevent the scrotal excoriation, you do the scrotectomy.
Yes,
along with the orchidectomy. Okay.
Okay, can I answer?
Yeah, one question, Dr. Archana.
Yes, sir.
What is the prognosis based on the lymph node involvement in 5-year survival in carcinoma penis?
Sir, if there is no lymph node, no palpable lymph node, it's 85 to 90% survival, sir. If it's unilateral single lymph node, then it's 70 to 80%. Multiple or bilateral is around 40 to 50%. And if there is involvement of iliac nodes, it's 5 to 10%.
Iliac nodes.
Iliac nodes.
Less than
10%.
20% roughly.
10%.
Okay.
Occult node also you should take into consideration because that is why T1B lesion is very important. Even if the T1B, the possibility of having a node is nearly 70%. Though even if you are not seeing a node, occult node, there may be nodes where you have to be definitely go for a superficial inguinal lymph node dissection.
Or-
Then followed up depending upon the results you get.
And sentinel lymph node biopsy is also recommended nowadays.
Yes,
If
sir.
you don't have a proven
Super.
lymph node metastasis on FNAC, right?
Mm.
That is also recommended in penile cancer.
Dynamic central node.
Then,
Good.
Mm.
Naval sir,
Yes, sir.
the only problem, your clinical examination.
yes, sir.
Very obviously, it looks like a varicose carcinoma. You are talking in a different language in your presentation. So if you and your terminology and all those things, though your theoretical knowledge is very good, but
Yes,
what
sir.
we see very importantly, your clinical knowledge. Looking at that lesion, what is there in the lesion only you have to present. If you are presenting in
Okay.
a different way, then you will be in a trouble. Otherwise,
Okay.
good.
Thank you.
Yeah, good presentation.
Thank you, sir.
Archana, do you have any doubts to be clarified?
Sir, sir, if the inguinal lymph node is palpable, for this patient, it was only very small, sir. It is not significant. Should we still consider as a clinical in one or?
When you are
Yes.
presenting the case, yes,
Yes, sir.
it is better you're talking about, because a single node involvement is also put as N1. It is on the higher side, because anyhow, if the node is palpable, if the FNAC is, even if it is going to be negative, you are going to do the superficial lymph node dissection.
Yes, sir.
That concept has come, not waiting for the 4 weeks for antibiotic. Then
Yeah, right. You can directly go for excision biopsy of the lymph node also. If single lymph node is there and
Okay, sir.
FNAC is not possible or FNAC is inconclusive, an excision biopsy also can be done of that lymph node.
Professor Erbas Omin, sir, do you have any comments or questions?
No, they have made both the participants had made a good efforts to present, and of course there were a bit of things which has been corrected. So I really appreciate her presentation. She has made efforts to do that, and the whatever the errors were there. So it's a learning experience basically.
Thank you.
Khanna, sir, any other comments, sir? Can we call a close, sir?
Yeah, I think she has done very good here. We can close.
Thank you, sir. Thank you. Thank you, Dr. Archana. And I
Thank you,
also
sir.
wish to give the
Srinivasan
cards
sir
and-
is missing, sir. Can I say?
Sorry, sir.
Srinivasan sir is missing.
Sir, he joined, sir. I think he left in the middle of the day, sir.
Okay. So your
He
guide is not
joined at
there.
the- Sorry, sir.
No, her guide is not here, because otherwise we will give a clap to Srinivasan sir usually. No?
Usually, sir, the guru is so confident to leave the candidate to defend herself. So that also shows the amount of confidence guru has on the child.
Thank you, sir.
Thank you very much, ma'am. Thank you,
Thank
dear
you, sir.
faculty. I thank Professor Erbas Momin, sir. Thank you for joining us in spite of your traveling schedule in the late evening. And
Thanks a
Hemant
lot, sir. Thanks for inviting. It was a great opportunity and learning experience for all of us.
Thank you, sir.
Thank
Thank you.
you, sir. Thank you.
And
Right, everyone.
I thank Dr. Hemant, sir. It's been quite
Yeah.
some time you've been with us, and thank you for staying with us till the end, sir.
Thank you,
And
sir.
Modi
Thank
sir
you very
had
much.
to leave early, and thanks all the faculty, Kanna sir, JLL sir, I think Karnakaran sir also left, and other senior faculty. Rajiv sir, good
Yeah.
night, sir. Any comments,
Good
sir?
night, sir. Good night. No, thank you.
Thank you.
So I wish all the faculty, Karnakaran sir is still with us. I think faculty all very happy festival days coming up, and we look forward for coming week. So we have one parotic case which has been confirmed for the next week, and we will also have one case of gastric outlet obstruction from JIPMER next week. These are the two cases for the coming week. We look forward for the next Friday class. Good night, everyone. And with the permission of faculty and the students, we call this session a close. Good night.